right, let's talk a little bit about acute rejection. Now, the first thing I want to say here is, again, we just talked about this in the last video. Don't confuse acute rejection with acute hemolytic reactions with blood transfusions, right? They're two different things. The acute hemolytic reactions with blood transfusions are type 2 hypersensitivity. Pretty much they're caused because of preformed antibodies. They're going to happen a lot faster, and they're more synonymous with the hyperacute transplant rejections. Okay, so that's number one. Number two, in all reality, hyperacute transplant rejections are pretty rare because usually we're going to be looking to match HLA antigens right before we go putting a organ in somebody. So you don't really see them a lot. However, the acute transplant rejection is actually quite a bit more common. It still results from HLA incompatibility, but maybe not to the same extent as the hyperacute rejection. The difference here is, remember, with hyperacute rejection, we're talking about preformed antibodies. We already have those antibodies, we just weren't matched really well. And so immediately those antibodies started attacking that graft, right? And within minutes, it caused thrombosis of the vessels around it. It caused ischemia and necrosis of the graft. Now, an acute rejection is going to happen on a longer period of time. It's going to be a rejection that happens within weeks to months. And because of this, it's not because of preformed antibodies, right? If it was preformed antibodies, just like we see with type 1 hypersensitivity reactions, happens immediately when that IgE is on the mast cell. Just like with acute hemolytic reactions, right? We had antibodies preformed, things start getting destroyed right away, possibly even during the transfusion. Here, though, it's going to take time for that reaction to happen. So let's just look at a couple scenarios to kind of get an idea of what we're talking about. So again, we have some donor. Okay, so here's my donor. And I'm just going to draw, we'll just do a kidney again, right? We did a kidney last time. So the donor is going to give a kidney to the recipient. And here's my recipient. Now this time, I don't have preformed antibodies to the HLA antigens here. But what can happen is, after this recipient gets this kidney, okay, after that comes in here, initially we might have some antigen presenting cells in this recipient. Okay, so I'm just going to put antigen presenting cells. And again, I'm going to go through this a little bit fast. And the reason is because we actually talked about this probably 5 or 6 times during the immunosection. So like I said, go back, check out some of those previous videos. But essentially what we're talking about here is this antigen presenting cell is coming from the recipient now. Okay, remember, this kidney came from the donor. I'm trying to keep it color coded for you. And so what can happen is this antigen presenting cell can say, hey, look, there's some HLA antigens on here. And then it could take a piece of this HLA antigen, and then it can present it to a T cell, right? So it can present this HLA antigen to a T cell. Again, the recipient's T cells can recognize this. Now, of course, this can go a couple different ways, and we talked about this in great detail already in the video series. But again, when this antigen presenting cell presents this HLA antigen, it can release certain substances, right? It can release interleukin 12. And if it releases interleukin 12, it's going to cause this T cell to become a T helper 1 cell. And then what's that T helper 1 cell going to do? It's going to release interferon gamma, right? And that interferon gamma is going to cause macrophage activation. And these macrophages, and what are they going to do? They're going to go and they're going to attack that tissue. Okay, but again, this whole process takes time, right? This T cell response takes time. This process here, right? This process here, along with potentially CD8 positive T cells, right? If you factor in some CD8 positive T cells here, so we're just going to put T cell, CD8, right? So you might have some CD8 positive T cells that also recognize these antigens and also start destroying the tissue here. And this whole process here really is going to be largely driven by destruction of this graft by macrophages, right? From a T helper 1 response and CD8 positive T cell activation. And we talk about this very frequently as a cell-mediated response. When we have cell-mediated responses, that's very similar to a type 4 hypersensitivity, okay? So that's a cell-mediated response. That's one possibility of something that can happen with this graft. Now, if this happened, what would you expect to see on histopathology? Well, you'd expect to see a whole bunch of T cells at the site of the graft, right? So CD8 positive T cells, potentially these are CD4 positive, talked about that, T helper 1 cells. You'd expect to see a whole bunch of these, and macrophages too, all around the graft. And so a good image of that is depicted here. You can see this is really a significant lymphocytic mononuclear infiltrate, right? It's infiltrating, in this case, the lungs, right? You can see these are all your alveoli, your alveolar tissues here. And when you see a bunch of lymphocytes in the tissue here, that's very consistent with either an acute or potentially a chronic transplant rejection. You might be saying, well, how do I tell the difference? Well, you look at the timeline, right? So acute rejections are going to be usually less than 6 months, weeks to months. If you're talking about a chronic rejection, it's going to be like a year out at least. Okay, but they'll look similar on histopathology. There are a couple differences we'll talk about. Things like fibrosis or more chronic inflammation is going to be more consistent with chronic rejection, right? The acute rejection is going to be more consistent with things like vasculitis. But again, if it's cell-mediated, it's very classic to see this lymphocytic infiltrate. Again, when I say cell-mediated, I'm talking about this process that we've gone through a few times now, but essentially macrophage and CD8-positive T-cell destruction of the graft. And that's what you're seeing here. All of these blue dots that you're seeing throughout here, this is this dense lymphocytic infiltrate. And you can also see here, and you can see here, these are all red blood cells. Right? And so you also have some intra-alveolar hemorrhage, probably from the parenchymal destruction of the lung here. Okay. And so, but again, what are you looking for? You don't have to be a pathologist. You're just looking for a dense lymphocytic infiltrate. Look for a whole bunch of lymphocytes everywhere, and then ask yourself, what's the timeline? Is it weeks to months, or is it, a year plus, right? Usually, like I said, less than 6 months is almost always going to be acute rejection. If it's like 10 to 11 months, you'd lean more towards chronic, or look for additional findings like fibrosis or vascular, smooth muscle proliferation, which I'll talk about in the next slide. Okay. But that's what we're talking about here with acute rejection. Now, the thing about acute rejection that's a little tricky is that this can be a cell-mediated response, but it can also be a humoral response. But it's usually not both, okay? So it's kind of like it's one or the other. Now, this is the cell-mediated response like we just talked about. Now, a humoral response would be a little bit different. So let's do the humoral response here on the bottom. Okay, again, we have our donor donating a kidney to our recipient. Okay, now the difference here is, again, there might be some antigens on here, some HLA antigens that are recognized by the antigen presenting cells. Okay, so the antigen presenting cells will recognize these. One good question here is, if the antigen presenting cells recognize these, what type of HLA are they recognizing? Well, it's probably going to be HLA-2, right? If it's an antigen presenting cell, it's probably going to present this to CD4 positive T cells. And if it does, we know that it's going to be MHC class 2, which means it'll be an HLA antigen that has 2 letters after the name, right? So these are all like the little intricacies of putting this all together. But again, the antigen presenting cell will identify this HLA antigen. It's going to take that HLA antigen and present it probably to a T cell again. Okay, probably to a T cell, probably a CD4 positive T cell, right? Especially if this is MHC2, right? According to our rule of 8s. And so then this T cell, if we're going down a humoral pathway, would probably become a T helper 2 cell, right? A T helper 2 cell can then go on to bind with B cells and activate B cells to undergo class switching. Okay, and we talked about all of this in the previous videos, right? Driven by CD40 ligand. And these B cells will then convert into plasma cells and start making a bunch of antibodies, right? They'll be turned into antibody factories. And this whole pathway here is going to be the humoral response. And a humoral response is going to be more consistent with a type 2 hypersensitivity. Why is that? Well, because we're making these antibodies. Where are these antibodies going to bind to? They're going to bind right to these antigens on the graft, right? So similar in some ways to the hyperacute rejection where we had preformed antibodies that bound to the graft. In this case, the difference is the antibodies are not preformed, right? We're going to have to take some time to form these antibodies and then have them bind to the graft because of potentially some HLA incompatibility or mismatch. But again, it takes time for that to happen. It takes time for the T cells to become T helper 2s, to then bind to B cells, activate them, undergo class switching, and eventually make IgG antibodies against the graft, as opposed to having preformed antibodies. So that's the major difference. But again, it's kind of the same mechanism after that point, right? It's really just type 2 hypersensitivity, complement-mediated destruction of the graft, largely driven by complement. Now, would you see, if we went down just a humoral response, what are some things that can help you distinguish that from the cell-mediated response? One of the big ones is we can look for complement in the graft. Remember, when we're talking about a humoral response, we're talking primarily about complement-mediated destruction. So, right, if I tag something for destruction and then I start having complement bind to this, right, eventually leading to a membrane attack complex to destroy the graft, well, that's going to be a little bit different than if I just destroy the graft using CD8 positive T cells and macrophages. Okay, so what we would do is we can look for complement markers. So if you use specific complement markers, one classic one is C4D. Okay, so if they tell you they use a complement marker on a histo slide, hemoglobin, right? Or immunofluorescence with a complement marker, and it's lighting up and it's positive. Well, then we think more about humoral rejection. However, if that complement marker is negative, right? If I'm not really getting anything when I use the complement markers, in other words, it's saying there's really not a lot of complement here, it's probably more cell-mediated destruction. Remember, with acute rejection, it's usually one or the other. Okay, it's usually not going to be both. So you're going to have destruction from one or the other classically, and that's particularly important to remember here. What's this going to present with? Well, edema to the graft tissues, so all the swelling, all of the inflammation, and eventually you'll have some deterioration of the function of that organ. In our case, we're talking about a kidney. What are some things you would see in a board question that would make you think, or even in real life, that would make you think that this patient potentially has some rejection of a kidney? Well, you would probably see an increase in their creatinine, right? The filtration, the GFR would be decreasing or declining. You probably see an elevation in the BUN as well. You probably have decreased urine output, for example, right? These are all things you want to look for in a board question. Again, it depends on the organ being transferred. And again, the classic thing here is we want to make sure we're matched from an HLA perspective, and we also can add in some immunosuppression. Now, if you have an acute transplant rejection, what you can do in these patients is you can kind of quote unquote blast them with high dose glucocorticoids and try to basically eliminate this immune response acutely. Okay, that's one option. It might not always necessarily work, but you can also have these patients on maintenance immunosuppression therapy, hoping that this doesn't happen.